so give him a little bit of a break. If I can accept him here. There he is.
Josh.
Man,
Sorry
I'm
about
glad. I was trying to explain this on my own, and I know that I'm not as versed in the research as you are.
My sincere apologies.
That's all right, man. That's all right. We know that schedules as ATs can flip on a dime. Everybody in here understands that. So no big deal. No big deal. Do you need a minute to catch your breath, or you all set?
And
so I tried to explain the Buffalo Concussion Treadmill Test a little bit, but we're just going to take this from the top. So I'm sure I missed some really key points. But there's, as I kind of started with this, but there's really some compelling evidence to support an early introduction in exercise after concussion. All right. So can you talk to me a little bit about like what those advances in the research are saying and kind of what some of the recommendations are now?
Absolutely. I think when we think about the theory behind that, and I think this distinction or this differentiation point of where we used to be to where we are now and where we're going, with the old recommendations really being you're going to sit and wait until you get better.
Right?
Yeah, theoretically, that really never made sense to me because, we look at just in sports medicine, at least, the things we most commonly deal with, there's not an injury that I'm aware of that I've encountered in my clinical practice where my recommendation is just do nothing and wait for yourself to get better. So that I had a hard time grasping that in that setting. But then when we think about it in more, context, I'm like, well, maybe the brain, there's, it's pretty important. Maybe that's why we're being so cautious. But then you look in all of the literature around stroke management and people who are recovering from strokes, traumatic strokes, they're exercising right in that acute window afterwards as well. And other traumatic brain injuries are following those same principles. So if for more significant, moderate, or severe brain injuries, we are actively rehabilitating those patients early, why for what's presumably a more mild form of that injury are we doing nothing? So I never really understood that. And then obviously this research is evolving where we're starting to apply that really logical theory to this injury, and we're seeing great outcomes. And what they're finding, there's a really nice study that was run in Canada across their emergency departments that really basic methodology, but really looked at 3 categories of post-concussion management, one being no exercise, one being unrestricted exercise, and one being moderate or kind of controlled exercise. And what they found is like the 3 little bears, that one right in the middle is just right. And the groups that did no exercise or did unsupervised, kind of like what they would normally do, both of those groups took longer to recover and had worse outcomes than the group that fell in the middle that was in that kind of moderate, symptom limited based exercise that was controlled and matched to what their tolerance is. And so when we think about some theory of application there, we come back to our pathways model that we were talking about in some of our early talks, and with the blog that came out this week around trying to identify what those impairments are and match our treatment to it. And using some of these exertional tests, we're able to really identify people that would benefit really strongly from active rehab that involves that physical exertion. And, even with the groups that don't have that physiologic deficit, we got a whole lot of other benefits that we can talk about why that group is important to do this too. So, for that, Josh, I'll turn that to you in terms of how you want to, cut up those different, different topics.
Yeah. I think, right now, I think the best way is just let's talk about how we introduce some of that early exercise, right? So how do we know, you talk about moderate exercise being kind of right where we want to be, right? Your Goldilocks analogy. So how do we know what that just right is, right? Like, how do we figure that out?
Yeah, fortunately, we got some smart people in the industry that have done some research and, again, use some logic. And Dr. John Leddy's group out of University of Buffalo It's really the first group that started to investigate this. And what they did was they took a protocol, the bulky protocol, which is used for exercise tolerance assessment in post-stroke patients, and they took the same concept and applied it to patients with sports-related concussion or mild traumatic brain injury. And so the operation of how they do that is basically trying to facilitate gradual progressive exposure to physical exertion. So the way that they do it is they utilize a treadmill, and they have some set parameters that we use to operate. So the first parameter being speed. That speed is going to be pretty consistent throughout the assessment. And it's, we have some considerations for an athletic population or a non-athletic population in terms of what's walking speed we're going to be moving at. This is a walking assessment. And our variable that we're looking to change first with constant speed is going to be the incline of the treadmill. And so we're using that as our intensity modifier over the course of minutes to gradually ramp up what that demand is for our body to operate at a higher energy consumption, process there, which is one of the big things that we know to be true about what happens after a concussion. When we think about the neurometabolic cascade that is a subsequent direct result of that brain trauma that causes a concussion, we know that that causes, in its most simplest explanation, which is where I love to live, it messes up that energy consumption and production mechanism. It screws up the balance of sodium and potassium in our production mechanism of ATP, which is going to be our main energy source for all cellular activity and metabolic activity. So when we are progressively increasing the demand for energy, we know that that pump has to be running at normal or high operating, abilities to continue to produce that ATP for our body to be able to sustain that exercise. And if it's dysregulated and it can't do that, well, then we're going to start to see some symptoms that develop as a direct result in the moment to that assessment. So we use that as our cutoff, based on what the provocation of symptoms are with this assessment. So we monitor that response, and we also monitor what the heart rate is at all of these time increments while we increase and change these variables that correlate with increased difficulty. So then when we get to that point where we know that there is a certain heart rate threshold and exertion level that this, that causes this patient to have a spike in their symptoms inside of our significant threshold, now we know where their ceiling is. So now when we want to find that Goldilocks range, we can use a smaller percentage of what that heart rate range is, so that we know if at 125 beats per minute, that symptom threshold increases uncontrollably, well, we're going to stay underneath that 125 beat per minute range and operate maybe at 75, 80% of that threshold and use that as our starting point for our exercise, because we know that that heart rate has already been tolerated and not resulted in that symptom provocation. So it's theoretically safe for the patient to do that because it doesn't result in any of that dysregulation.
Okay. So like if you've got a patient that comes to you, you know that they were concussed, 48 hours ago, right? Because that's pretty much you don't want to exercise them before that, right? Pretty much 48 hours is going to be the minimum amount of time.
Yeah, that's what I'm working with.
Okay. So let's say it's 48, 72 hours later, they come see you in the clinic and you say, okay, we're going to do the Buffalo Concussion Treadmill Test or the BCTT today. What's your process?
Yeah. So entry point is, we use symptoms as our big benchmark for, progress across the, gamut of our monitoring of recovery and concussion with where we're at right now with how we can determine what recovery is. So we use that to inform what's, green light, red light for us to be able to move forward with or, pump the brakes with. So naturally, every investigative tool that we have, everybody has their own scale. We talked about the the symptom scale associated with the SCAT-5, that's that 0 to 6, 22-item scale. And when we talked about the VOMs, we referenced their 4 symptoms that they're most interested in their 0 to 10 scale. Naturally, the BCTT has their own scale as well. They combine all of the symptoms that the patient's experiencing and try to use one number that represents that symptom burden. So we still use 0 to 10, with 10 being most intense, 0 being absent, but it's an overall representation of all of the symptoms together to inform what that number severity is of symptom burden. So we start there so that I have that baseline number. Then I start with a baseline heart rate because we know that there's going to be disruptions to the cerebrovascular supply as concussion and changes to the sympathetic nervous system. So we could expect to see some alterations with our sympathetic, parasympathetic nervous system and what that resting heart rate looks like. So I want to see what it is resting. So then when we exert it, we can see what that difference is. And those are my first 2 data points that I take. We utilize heart rate monitoring. We have some heart rate monitors that we use. There's a whole mess of, wearable technology options that exist in today's market at various price points to be able to help, supplement with this. Or the old-fashioned free way, you could take, a heart rate. You could take your pulse with, just time and, palpation. It's a little bit more cumbersome, but you could certainly do that in a real financial pinch. So what we're doing is we get them on the treadmill. Obviously, we clear our contraindications. We want to make sure that there's no concurrent lower extremity injuries. Nothing that I'm nervous about this patient being unsafe to walk on a treadmill. If there's any of those comorbidities, then we obviously have to reevaluate our evaluation environment. So that's first and foremost always. Secondly, our criteria for stopping our test is when the symptom number increases by 3 or more. So if this patient's at an 8 out of 10 at the jump when I'm getting ready to do this assessment, we're going to be ceilinged out already. So I'm probably going to wait to do that formal assessment until we have a little bit of symptom reduction there so that we can get a more accurate, assessment of what that provocation and spike is. Then, we get them on the equipment. We get them up to speed. We utilize 3.6 miles per hour as our speed through this assessment. And then, we have a sheet that one of my colleagues made. I'm going to explain what all of this is in a second, but that makes this really, really easy that we use. So we have it in an Excel document, and our column on the left-hand side is our minutes here. So we can see what minute of the assessment we're engaged in. Then the next column down is the heart rate. So we're going to measure that every other minute. And for people like me that are visual learners, I can't write where there's a big black square, so I'm going to skip that minute and go to minute 2. Our next column down is symptoms. So every minute we're going to ask and check what that 0 to 10 symptom number is so we can measure that response as we move forward. Next scale is RPE. We use the Borg's, we use perceived exertion rating by the Borg scale, which I'll show you in just a second. We have a scale for that to help make that easy. We measure that every minute. And then this next spot here is for the incline, which we're increasing every minute by 1%. So we'll increase that, record what our incline is. And then lastly, our speed, which should be constant throughout at 3.6 miles an hour, unless we max out our incline, and then speed is our remaining variable that we can increase. I've not ever gotten a patient to that point before, but that certainly is our emergency plan there. Things to help make it really easy. Like I said, this sheet right here that also has my stop criteria down there at the bottom. If my RPE is 19 or 20, or if my symptoms are increased by 3 or greater. And then on the back of my clipboard, I have this taped on the back of it, which is our scales. So we have on the bottom, the emoji scale for 0 to 10, what level of distress or you're in. So that's our 0 to 10 symptom scale. And then we have the exertion scale on that 6 to 20 point there. What's really nice with this is, having colors in there and descriptors to give the patient some context about what a 10 out of 20 means on the exertion scale. Gives them that context with green, yellow, red to put it into some patient-friendly language so that we get a nice, accurate representation of what their exertion is.
Yeah, that's great because like having all that stuff ready to go. The first couple times you do it, there's a lot to think about,
Oh yeah.
right? Like this, I'm measuring this here, and not this, and now I got to do this. So having all that prepped and ready to go is certainly helpful there. So let's say you get somebody through it, right? They have to be stopped, and their heart rate when they stop is like 140,
Yeah.
right? And you say that it's take like 80% of that. Okay, so you kind of have that heart rate. You monitor them a little bit before they leave. Uh, they leave later that night, and then they come back the next day, and they say like, "Look, I was good for a little while, but then kind of later on that evening, my symptoms kind of started to climb up a little bit, or they start exhibiting a new symptom or something like that." How does that kind of impact your plan the next day? Because if you were planning on saying like, okay, well, we were going to go, to this heart rate today for this amount of time, how does that kind of change your plan?
Yeah. So, as most of our principles are, if we look again to, other things that we do on a daily basis in our clinical practice, and we lean on, again, not a clean comparison from, soft tissue SAID principle and, overload principle or progressive overload principle, but the same concept is what grounds my theory on how I manage this, where I want to try to understand what that level of provocation is for the patient, because we're trying to, operate in an area of their tolerance where it's not going to, impact their recovery negatively. But we do sometimes with some of our rehab, we expect there to be a response. So if we find like that circumstance where over the course of the day things are, becoming a greater challenge and worsening, then that would be a sign to me that perhaps we push too hard and we just need to dial back our intensity a little bit for the next session so that we can try to get a little bit more in that sweet spot. If, for example, they had, more of a short-term, immediate after the exertion response that then dissipated as the day went on, well, that to me is kind of like that soreness I expect when I'm doing an eccentric tendon loading program for somebody with Achilles tendonitis. That's, that kind of progressive overload, little bit of response, but not something that's going to impact what that progression is.
Okay, so it's not a full stop moment where you let them rest again and let their kind of symptoms calm down. It's okay. We just won't go as high on the heart rate.
Yeah.
To exert. Okay. Now I know this question gets kind of asked a lot, right? Does this, as you kind of raise up their heart rate, could this be counted as like the first step or two of a return to play protocol?
So the way that I practice, this is kind of like the step before the return to play protocol starts. So this is like that step 0 for me, which is symptom limited activity. So it's not the formal return to activity progression. And why that's the case for me is, if we think about how we're determining this exercise range, and we compare that to what that kind of first accepted consensus stage is of the return to sport strategy, we're operating with a percentage of less than their max heart rate. So we know we're already going to be at a lower threshold of what their heart rate expenditure is. And we know that what we're really looking to do in that first stage of the formal return to sport strategy is we want to be from that max heart rate threshold and a small percentage there. So we're just, instead of being up here, the BCTT has us operating somewhere, down here. So there's this gap that we have to be able to account confidently for. And I just don't think we can confidently do that if we're not at that, close to max heart rate threshold. And, if we're doing that with the BCTT, then we've completed it. There's been no symptom provocation. Then it's just, then we're not in that rehab category. We're just in exercising. And then that's something different, because then we're operating at their actual max and not that kind of sweet spot sub-max threshold where we try to live when it's symptom provoking.
Okay. So now what criteria do you use to say like, okay, well, they're ready now to start that return to play protocol? Like we're out of step 0, right? Is that just kind of strictly between you and the rest of the care team and the team physician to make that decision? Or is it just kind of, okay, once, they're not getting any more symptom provocation with exercise, we can start that? How do you strike that balance?
Yeah, it'll definitely be a multidisciplinary decision, in consultation with our care team. But the nice thing with this protocol, the exercise protocol, is we have some built-in progressions where if we're having a patient who's in this rehab group for say 3-4 weeks, we can increase that heart rate, that target heart rate zone, each week. So we're naturally progressing closer to what that ceiling is. Generally what we're looking for to initiate that return progression in any circumstance is going to be a return to baseline, by, what our definition of baseline is. So symptom status, neurocognitive status, performance. We certainly don't want symptoms that are provoked with exercise other than, what we typically expect. If somebody's doing a max exertion, they're going to feel some fatigue, et cetera, but not, concussion specifically provoked. So if we have somebody that has returned to their baseline status, and has, graduated through what our progression is through the exercise progression, well, then we're ready to take that next step back into the formal return to sport, protocol or strategy.
Okay. And then like, how often do you repeat this? Is it something that you do like weekly, bi-weekly, anything like that? Or do you just kind of get a baseline and then if they don't have any more issues, you just kind of keep progressing them?
I'd say typically this tends to be something that I'm doing once to twice, just based on, I work with collegiate athletes, and we know that 85% of that group is going to recover within that 1.5 to 2 week range from their concussion. So from just a time availability perspective, I'm not usually in that rehab process for the vast majority of my patients long enough to do it more than twice. Usually what I would look for is every 2 weeks would be my time point in a shorter term setting. If this is a patient who we're in post-concussion syndrome and it's going on for 3 to 4 months, I might do the assessment monthly as opposed to twice a month. But in more of our short-term, more accelerated recovery group, usually at that entry point is where I'm doing it. And then if our care is extending beyond 2 weeks, I would repeat that again, but also can use that as a little bit of an exit, kind of clinician rated outcome measure to be able to expose that patient to that progressive activity and ensure that they have the response we want. Same way we could use that VOMS, where if we have an abnormal VOMS or BCTT at our intake process, we're going to want those to be normal before we discharge them. So using them as a pre and post treatment mechanism to assure normalize is a nice strategy as well.
Okay. So now I know there's always just some outliers and some things that happen. So I want to go through just like, if this, then what?
Yeah.
So let's say you've got a patient that you go through, they start either with no symptoms or very low symptoms, and they get all the way through. And the only reason that it's stopped is because they either reach the max of the rating of perceived exertion, or, they're just able to keep going and they never have a symptom provocation. But they're telling you, in class or just in daily life, they're still having some issues, whether it's difficulty concentrating or, looking up at the board in class or what have you. But, how does that kind of impact your management plan? Is that telling you that maybe it's something different? What are you doing there?
Absolutely. Those types of symptoms would make me start thinking more about a vestibular ocular, deficit. So that's definitely where I would try to hang my hat on what our screenings are, for that pathway, and then some active treatment in that regard as well. And that would be really the focus of what my care plan would be. But I would still maintain, if we're able to have that physical exertion safely, I would maintain that as a part of my rehab process for the power that physical activity holds on preventing secondary complications from developing. So we also know that when people are not physically active, that causes a whole mess of emotional and behavioral dysregulation. And all of those types of symptoms can magnify everything else that we're experiencing. So if we can maintain physical activity, it'll promote better sleep regulation. It'll have, the patients have better, mental and emotional states because of what the endorphin release and serotonin release is from physical activity. These are high level athletes, that I work with. So it maintains a little bit of their identity, that they're able to keep that connection with something that they find really really strongly passionate about. So we can keep all of those things operating smoothly while we focus our rehab on maybe some of those vestibular impairments, and use the physical activity to help support and supplement that process as well.
Okay. So pretty much if they're able to tolerate the exercise, then it's time to start looking at some of the other pathways that you touch on in your blog, right? Whether that's vestibular ocular, like you mentioned, or I'm going to mess them up because I always forget them, but cervicogenics, one of them, right? And then I think behavioral and what's the last one? I'm missing one.
Oh, that's good right there. And physiologic. Yeah. So what we're thinking to be the main bread and butter for when there's going to be that energy disruption.
Okay. So so if they're able to get through, look for another source of the symptoms that your patients have.
Exactly.
I know you touched on this a little bit early on with lower extremity injuries or somebody that symptoms are too high. Are there other patients that you just would not do this with?
I think it depends on setting. If somebody's operating in a setting where they're working with, more elderly based patients, that's obviously a consideration there on what their general mobility is. And I think a barrier period is going to be resources, and if people have access to the equipment. I mentioned, some workarounds for heart rate. Obviously if you have a heart rate monitor, that's the easiest, but you could use a pulse oximeter. You could take, pulse the old fashioned way through palpation. But if you don't have a treadmill, that's obviously a barrier. Fortunately, in subsequent years, John Letty's group has developed a protocol for using a stationary bike, and uses, body weight and wattage, and also, the RPMs to determine what that intensity is that you're going to use as a progression point on the bike. There's a really great manual that they have in circulation for that. But generally, if you don't have access to equipment, we just got to be, we got to be creative and use our concepts where we try to control as many variables as we can, but expose the patient to that, some type of consistent physical activity, walking outside. We can modify the speed they're walking at, or we can find some hills and some inclines for them to walk up, just different ways for us to increase that heart rate with us still being able to monitor that exertion, symptom provocation, and hopefully also heart rate. So we can be more scientific in how we phase that. But certainly if you have very limited access to resources, and we can only go by symptoms and exertion, that's something that we can work with scientifically, and we can use those as brackets and parameters.
Yeah, that's a great point, because I know that their resources are limited a lot of places. So being able to have those workarounds and just to think like, oh yeah, hey, I could I could just have them kind of walk around the track, or we've got a hill that they always run for practice anyway, so maybe we could start just doing a little bit of walking on there. So being able to kind of pivot from that, that's really helpful. So you kind of took my last question there with what if I don't have a treadmill and what equipment do I need? You kind of hit on all that. So I appreciate that. I don't know if anybody watching has any questions that they want to drop in the chat. That now would be a great time. But other than that, just to kind of touch on what we talked about last week, it looks like Mike White was not the answer for the Jets. And now they've got, looks like Flacco starting on Sunday.
Oh, yeah, baby. Chuck and coming back. Can't spell elite without Joe Flacco.
Oh, man. Well, we'll see if he's got anything left in that arm. But Nick, as always, thank you so much. I know you've got a few more blogs coming out, so we'll keep an eye on those, kind of touching on more of the VOMs, the BCTT, and also talking about some vestibular, what you can do with when they're having vestibular issues with the BPPV, which is another fun acronym in all this. So thanks again. It's always a pleasure talking to you, and really appreciate your insights and wisdom with this.
Hey, thanks for having me. It's a lot of fun to talk about this stuff, and hopefully has some deliverables for people to be able to bring in their practice and impact patient care in really easy and direct ways.
Yeah, that's what I like about a lot of this, because you broke it down really simply. It can be really scary to kind of implement some of these things. But with the VOMs and with the BCTT, if you're just prepared beforehand, they're really straightforward to run, and they give you a lot of really good information on how you can treat your patients.
Could not agree more.
So, all right, Nick, thanks again. Have a good rest of the day, and we'll talk to you later.
Thanks so much, Josh.
Yep. Bye.